And so as we move on, there's two videos here. These are fairly short that I'm going to show you. And we're going to look at, the first one will be, we're looking at retractions and increased work of breathing. There is some narration with this in the middle. This is from a physician in an emergency department, and he'll be describing a little bit of what we're seeing and hearing.
We go in this guy's room?
Most likely, yeah. We'll see. Sometimes the pediatrician, depending on who's on, they might say, no, we can treat this here, and then if he doesn't improve, then we transfer him out.
Hello there, Dr. Carlo Oyer. In this video, we're gonna see a very clear example of respiratory stress. This patient had clear intercostal retractions, which is when each patient takes each breath, you can see the ribs coming out underneath the soft tissue. And this is just a superb example of intercostal retraction. But he also had suprasternal retractions as well, which we'll see in the video.
So this is what we call suprasternal retractions. You see the soft tissue becomes more prominent every time he breathes because it's pulling. These are what I call intercostal retractions. Every time he breathes, we can see the ribs. And those are obvious signs of distress. And of course, the speed of the breathing, which is what.
Yeah, I even tried to tell him to put his hand over his head.
So as we go on to the next video, before I start the video, I want to explain what I want you to look for. I want you to look for two things. Watch the nose of the infant here, and especially at the very beginning, and you will see what's called nasal flaring. This is an indication of respiratory distress. It's usually seen it's seen more often with infants and young children. However, you can see it with adults as well. And then also, at the same time, look at the chest and watch for the retractions that you saw in the earlier video as well. So now we're going to move on to the cardiovascular system. One of the things we want to look at is there trauma to the thorax. And again, we want to look at the front and the back, also the side. But anytime we're looking at the cardiovascular system, we have to remember that there's, again, two sides. We're three-dimensional. We want to make sure we listen for breath sounds because cardiac problems can have altered breath sounds as well. And then also we want to consider the pulse. What is the rate, the quality, and the rhythm of the pulse? This chart shows ranges for different age groups for pulses. And we can see with infants up to 3 months of age, we'll have pulse ranges from 85 to 205. And then with adults, our pulse range is 60 to 100. And this actually applies to most older children as well. Older than 10 years old, they'll typically be in that 60 to 100 range as well. So if someone is outside of these ranges, then it's being caused by some problem typically. So again, we want to look at the rate as we just. We want to look at the respiratory rate as well because. All of the body systems that I went over earlier, all 11 body systems, are interconnected in one way or another. And the cardiovascular and the respiratory system are very tightly interconnected. We want to consider the blood pressure. What makes, one of the things I want you to think about and be ready in class is what makes the blood pressure. what causes blood pressure. And so think about that and be ready to answer that in class. But again, we look at, we want to find out what's normal with all of these, with pulse, respiratory rate, blood pressure. It's important to know what's normal for that patient. So if the patient has, for example, high blood pressure, and their blood pressure is normally 160 over 100, then that's their normal. So it's important to realize that, where, if that patient, has a blood pressure of 180 over 110, then that's hypertensive for them. And so, again, there's a reason that that's being caused, so we need to try to figure out what that reason is. We'll look at skin condition. We want to look at color, temperature, and moisture. Color is a good indicator, skin color is a good indicator of cardiovascular system, because as the body begins to have problems, if we're, for example, going into shock, the body will pull blood from areas of the body that doesn't need it. So, for example, the skin does not need blood that the brain and the heart and the lungs need, for example. So it will pull blood, which will make the skin pale, for example. With other conditions, it could be very red. And with other conditions, it could be cyanotic or have a blue tint to it. So we'll talk about all those. And then we'll look at the temperature. Skin temperature, again, is very important. Blood flow to the skin maintains skin temperature. So again, if the color and temperature are poor, then it means that there are probably problems with somewhere in the cardiovascular system. And then also we'll look at moisture. Our skin is usually dry. So, if it's very wet, we want to, take notice of that, and we'll talk about why that happens. Also, if it's extremely dry, meaning that we may be dehydrated, we want to take note of that as well, because those all indicate issues with those body systems. So the official name, the medical term for blood pressure cuff, is a sphygmomanometer. It's a mouthful, so you can just call it a blood pressure cuff, but at least if you see that term, you will know what it is. Blood pressure should always be taken manually before being taken automatically. So most of the time today in healthcare, we have automatic blood pressure machines, and even in hospitals and pre-hospital. But machines can make mistakes, machines can fail, and machines can have errors. And so it's always important that we take a blood pressure manually to get a baseline, and then use our automatic monitors to confirm that on a regular basis. And then if we have a vast alteration, whether it be higher or lower, then we need to go back and recheck that blood pressure with a manual blood pressure as well. Palpated blood pressure is used when it's very noisy. It should not be used just as an easy way to get a blood pressure. The palpated blood pressure will give you the systolic, or the top number of the blood pressure. The bottom number is called the diastolic blood pressure. So the top number, the systolic, is when the heart is contracting, and the bottom number is when the heart is relaxing. And so that's why there is a difference. And the difference between the systolic and the diastolic is called the pulse pressure, and we'll talk a lot more about that in the future. So again, we need to know what normal is, what's normal for this patient. Hypotension is a blood pressure that is lower than normal, and hypertension is a blood pressure that is higher than normal. And here in this chart, you see normal blood pressure ranges for different age groups, and this shows the systolic blood pressures of these various age groups. Next, we'll move on to our neurologic assessment. This is for any patient with any of these, or anytime you think you need to do a neurologic assessment. So any patient with changes in mental status, possible head injury, stupor, dizziness or drowsiness, or syncope. And so we'll talk more about each of these as we move through the course. Syncope can be a symptom of a lot of different things. Can be a symptom of cardiovascular problems, can be a symptom of neurologic problems. So we'll talk a lot about syncope as we get into different medical conditions. So moving on with our neurologic assessment, we can evaluate their level of consciousness and orientation. With this, we can use the mnemonic, AVPU, AVPU, and it stands for alert, verbal, painful, and unresponsive. So 4 different levels, going from alert from the most oriented to the least oriented of unresponsive. So are they alert to where they're at, who they are, and that sort of thing? Are they alert to verbal only? So when you speak to them, is that the only way they will respond to you? Are they alert or conscious to painful stimuli only? So again, this is someone who might be unresponsive initially, but you apply a painful stimulus and they begin to wake up. So this is a lower state of consciousness. And then the lowest state is unresponsive. So you have alert, verbal, painful, and unresponsive. Another way to get a guide is to use the Glasgow Coma Scale. The Glasgow Coma Scale was not really designed for what we use it for today, but EMS has adopted it, as well as most of medicine has adopted it. So as we move forward here, we'll look at it. The Glasgow Coma Scale has 4 different things that we look at, and then their response to that, they get a score. So we can see that with eye opening, there is 4 different things we're looking for, and the scores are 1 to 4 on each one. So none in each of the categories is a 1. So we look for their best verbal response, and so the scores there are 1 to 5. And we look for their best motor response, and the numbers there are 1 to 6. So naturally, with a total score, you can see that you could be in a deep coma or even dead and have a Glasgow of 3. So there are no Glasgows of 0, 1, or 2. 3 is the lowest you can go. 15 is fully alert. Typically, if someone is at an 8 or 9, they typically need some sort of airway control. So that's a kind of a guide to look at. If they're 8 or 9 or below, they typically will need some sort of airway control. So as we continue on looking at the neurologic assessment, we look at pupils. So again, it's important to know what are normal pupils. And so the pictures here show different types of pupils. So pupils are normally round and equal in size. So the top picture here, you see that you see those pupils are equal and round. Pupils will constrict when light is shining in the eyes. So this is because the eyes constrict to let the pupils constrict to let less light in when you have bright light. And as you're in a darker environment, your eyes will dilate so that the body wants to let more light in so you can see. And then also you can see at the very bottom that is constricted pupils in the photograph here. And then the third from the top is called anoscoria. There are medical conditions that can lead to anoscoria. You see the pupil on the left side of the patient there is larger than the pupil on the right side of the patient. So there's a small number of people who normally have anoscoria. If they're able to talk to you and tell you their medical history, they will usually tell you this because they are typically very well aware of that. And then we also have another mnemonic for pupil assessment, PEARL, P-E-A-R-R-L. And this stands for a description of the pupils, typically when they're normal. So it stands for pupils are equal and round, regular in size, and reactive to light. So if that's the case, instead of, for example, writing all that out, and PEARL is an accepted medical abbreviation, so you can actually state the pupils were PEARL, which means that they're equal and round, regular in size, and reactive to light. So if they're not each of those things, then you would have to describe what each of those things are. And then the other picture that's here is how to measure size. Pupils are measured in millimeters. With a little bit of practice, you will get to kind of be able to judge what pupil sizes are. But there's also helps out there. There's various like rulers and other pieces of paper, field guides and such that have this type of picture on them where it shows you, and you can kind of compare what does this patient's eyes look like. So continuing on with the neuro status, we're looking at neurovascular status. So we want to look at, does the patient have bilateral muscle strength? So again, we're comparing bilateral sides. We're comparing right to left. So do they have muscle strength? We want to test for pain, sensation, and position. This will be important because anytime we splint any part of the body, we are going to check for pain, sensation, and position each time, before we splint and after we splint, and then periodically through our reassessment, as we'll talk about here in just a little bit. We always want to compare distal and proximal and right and left. So if we're looking at arms, we want to make sure, if we're looking at sensation, we want to make sure the top of the arm has the same sensation as the bottom of the arm. The same with the legs. But also we want to make sure that the right has the same type of sensation that the left has. So we want to compare distal and proximal and right and left. And I know we haven't gotten into medical terminology yet. Distal is further away from the body, proximal is closer. So if we're talking about an arm, for example, the elbow would be proximal to the wrist, for example. The wrist would be distal from the elbow. So now we're going to look at some anatomic regions that we will want to look at from time to time with secondary assessments. So the head, neck, and cervical spine. We'll look at the chest, again comparing left and right, top and bottom. The abdomen has 4 quadrants. This picture shows those 4 quadrants. They're identified as, again, left and right, upper and lower. So you have the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. And then we'll look at the pelvis. We'll assess the pelvis. Then we'll assess extremities, both arms and legs, again, right and left, top to bottom. And also we want to make sure that we don't forget the back of the body, the posterior part of the body. Again, we want to look for symmetry. Do things move, or right and left comparable? We want to look for any open wounds. We'll also want to palpate the spine from the neck to the pelvis for tenderness and deformities. So as we move on to reassessment, we want to make sure that we perform our reassessment at regular intervals. At a very minimum, critical patients need to be reassessed every 5 minutes. Non-critical patients need to be reassessed at least every 15 minutes because things can change very quickly. A patient can go from non-critical to critical very quickly. So it's important that we reassess them and keep any changes in check or any deteriorations in check. And we also want to know if they get better as well. With our reassessment, we want to repeat our primary assessment. We're going to reassess our vital signs, comparing what we get now to what we got earlier. We want to look for any trends. Is the blood pressure going up or down? Is the pulse rate going up or down? Respiratory rate, is it going up or down? We want to reassess the chief complaint. Is your treatment helping them? So, if they called you for chest pain, is the treatment you're giving them helping them at all? And also, are there any new complaints? Many times, once patients get with EMS or a healthcare provider, they call for one problem, they end up having multiple complaints. So we want to know, are there new complaints that weren't that they didn't tell us about before? And then we also want to recheck our interventions. We want to go back and recheck our ABCs. That's in the primary assessment, but especially if we have provided some sort of airway for the patient, if we're breathing for the patient, or if we're doing circulation, meaning CPR, for the patient. We want to recheck those interventions periodically to make sure that they are still effective. We want to recheck if we have managed bleeding, either with a bandage of some sort or with a tourniquet, that we reassess to make sure that it's still under control. And then we want to look at the adequacy of any other interventions. Is there a need for new interventions? Is there something that we found in our reassessment that now needs some sort of intervention that we didn't provide before? And then we have a variety of monitoring devices that we will use. First is pulse oximetry. Pulse oximetry indicates the oxygen saturation of the hemoglobin, and we will talk about that as we get into anatomy and physiology and the cardiovascular system more. But it's an indication most of the time, not all the time, most of the time, an indication of how well oxygenated a patient might be. And then we have our blood pressure cuff, or our sphygmomanometer. Along with this, we would need a stethoscope to be able to hear. And again, we're going to be practicing these on each other. We have our blood glucometry, which is our checking of blood sugar with our glucometer. And then we have capnography, which we will be looking at as well. We'll be looking at waveform capnography, which is the waveform you see here. And we'll also be looking at the quantitative capnography as well, which you see in the upper right corner of this photo, where it says EtCO2 is 35 to 45 millimeters of mercury. So capnography is looking at the end-tidal CO2, so that's what EtCO2 means. And the normal end-tidal CO2 is 35 to 45 millimeters of mercury. So we will explain this more once we get into airway management and respiratory problems. So that concludes this video. If there are questions, write them down and bring them to class, and we'll answer those.